do you both have a success story or an inspiring story to share with our audience?
Well, I can tell you my own success story, if that's
great.
So, as I said, I suffered with infertility. Well, I had very, very irregular periods for 10 years. And when I was younger, I didn't really think it was going to affect my fertility at all. It didn't cross my mind. I just thought I wasn't having periods. And some years could pass without anything at all. And when my husband and I were trying to conceive, we thought it was just happen and it wouldn't be a problem. And then it didn't. So we had IVF. I stumbled across plant-based nutrition during the treatment. Initially, I was skeptical because I'm a dietitian and I was taught that dairy is the best form of calcium and that meat is the best form of protein. And I was concerned that I was going to give my baby, if it was successful, nutritional deficiencies. So, cutting out meat wasn't a problem for me, but I carried on eating fish and dairy. And it wasn't until my son was 6 weeks old and got diagnosed with cow's milk protein allergy, and he was really poorly with it, that I just gave up dairy overnight because I was feeding him. And from that moment on, I was whole food, plant-based, haven't looked back. And within 2 months, my cycle had returned to normal, 28 days. And for the last 2 years, it's been 28 days.
Ulrich, you have mentioned before about the importance of male fertility, and before we talked, you brought some shocking stats to sperm count and the form of the sperm that we are seeing nowadays.
Of course, yes, indeed. The sperm quality is measured, or the semen analysis is given as a normal by the WHO. And when I started my career somewhat 30 years back, it was normal for men to have 15% of normal sperm. So that means always 85, well, supposed to be abnormal. But that figure has now been readjusted to 4%. And I find that quite shocking that over the span of only 30 years, so within one person's life, career time, this has changed so dramatically.
Hello and welcome everyone to Afternoon Tea. I can see so many faces who have joined us before. Hello Janet, hello Joanna. Welcome to Afternoon Tea. If we haven't met yet, I'm Dr. Linda, emergency medicine physician from Sheffield. And I'm here with my lovely co-host, Dr. Erica, who is a GP in the West Midlands. And we are both lifestyle medicine physicians. In the chat below, please introduce yourself. Let us know where you are tuning in from. And if you have any questions, just drop them down in the chat and we'll get to them after the interview.
Hi, everyone. So as a society, we have come to view chronic diseases as the norm, but this doesn't have to be the case. And actually, your genetics are not your destiny. Both Lynn and I use lifestyle medicine and nutrition to help our patients combat chronic diseases. And Afternoon Tea with Docs was born out of our shared passion to empower everyone with these lifestyle and nutrition practices, our experience, and also the knowledge of our expert speakers so that everyone can live a long and fulfilling life. And if you haven't met us before, you can connect with us on Instagram, Facebook, watch the replays of our previous sessions on YouTube. And we are here for Afternoon Tea every Sunday at 5 p.m.
And the theme of the month is women's health. Every single month is themed to a different chronic disease. But in March, we are talking about everything in infertility, endometriosis, and so much more. And today we are so delighted to have two experts in the field of infertility, Dr. Ulrich Bartels and Lisa Simone. Dr. Ulrich Bartels is graduated from medical school at the University of Göttingen Germany, and completed his specialist training in Germany and Ireland. He worked as a consultant obstetrics and gynecologist at the NHS Fernley Park from 2001 and 2005. And since 2005, he has been practicing in Castlebar, Ireland. Dr. Bartel is interested in food and lifestyle as medicine, integrates this passion in his daily clinical practice in women's health.
Lisa Simon is a registered plant-based dietitian with 7 years experience in the NHS. She specialises in gastroenterology and fertility and works at Plant-Based Health Online, the UK's first CQC registered plant-based online lifestyle medicine health service. Welcome both.
Hello.
Hi, thanks for having us.
Yeah, thank you so much for organizing this and for having us joining you all. You're all very welcome, and it's lovely to talk to you.
It's a fantastic opportunity to talk to experts like yourselves who are seeing this ever-growing problem in our society. As you mentioned in your amazing paper, Lisa, 1 in 7 couples struggle to conceive. That is 14% of couples, and 1 in 4 couples, we can't find the cause. It must be so frustrating for people who are trying to conceive right now but can't, and they don't know what to do.
Yeah, really, really frustrating, and you know, I'm a massive advocate for getting men involved in the conversation as well, because it's thought that 50% now, or even slightly more, of infertility cases is down to male factor infertility, and out of that 50-ish%, around 40% is down to environmental and host factors, so that's diet and lifestyle. And I think that, you know, men can be quite nervous about talking about infertility. They can feel embarrassed or, you know, maybe ashamed, and that really shouldn't be the case. And so I'm really passionate about getting them involved in the conversation, and we should be treating each couple as a whole and not as separate halves, because we can give all of the advice to the woman, which of course is super, super important. But if we're not including the man, then we're only doing half the job.
Mm-hmm. Absolutely.
As you said on your fact sheet, it takes 2 to tango.
Absolutely. It really does.
Ulrich, you have mentioned before about the importance of male fertility, and before we talked, you brought some shocking stats to sperm count and the form of the sperm that we are seeing nowadays.
Well, that's right. So thank you, Lisa, for opening this up. And yes, you're very right. It's very important to have the men straight away involved in that conversation. And of course, there's two aspects of it. What you were just mentioning, Linda, what I sort of earlier said was, yes, indeed, the sperm quality is measured, or the semen analysis is sort of given as a normal by the WHO. And when I sort of started my career somewhat 30 years back, it was normal for men to have 15% of normal sperm. So that means always 85 were supposed to be abnormal. But that figure has now been readjusted to 4%. And I find that quite shocking, that over the span of only 30 years, to within one person's life, career time, this has changed so dramatic. And one has to sort of admit that this probably is just a concession to environmental changes which have caused the decline of normal sperm counts over that short period of time. And we definitely have to look at environmental toxins here. We have to look at chlorine. We have to look at PCBs, at fertilizers, which are going up the food chain, if you're looking at animal products. And I may sort of come on to fish later on, which is particularly sort of a significant example of that. But the other example, what you're sort of already sort of saying, Lisa, there, and one thing with male infertility is, of course, erection problems and sort of coming together at all. And because of the erection problems, it's very much like a red flag for any man to have even the notion of it could be his problem. And in fact, I've actually seen couples who broke up over the issue of the semen test, because he wouldn't go to the semen test, so much so that the couple actually broke up over that, because she was pressurizing him to have a semen test. And unfortunately, I had this rule in my gynae clinic. I said, okay, we do all this tests for you, and then when he has been to the semen test, you come back. But then she never came back, or she came back 3 years later with a menstrual problem. And then when I asked what happened to the infertility, she said, well, we broke up because of this. So it's a very, very emotional issue for men, and the pressure is very, very large. And I had a very unfortunate couple the other day where they were coming for another, or she was coming for another reason. And what happened is that he had experienced erection difficulties. Then in order to prove himself, he went on to an affair. And then, of course, she found out, and the marriage, of course, was in shatters and all that. And when you actually looked at all that, what had happened? When you got to the bottom of the story, he had gained weight. He probably had got cardiovascular disease. And yes, when I asked further, he actually had heart problems. He had heart pain. He had seen his GP. So he probably developed an erection problem because of cardiovascular problems. But then in order to compensate that, or to prove his point, he sort of went into this affair to see, can he still do it? But obviously that wasn't going down well with the wife. And obviously the whole relationship broke down. So I think it's a very, very complex issue, this male psychology on the one hand side, but also the very close link to actually pure organic symptoms, which is the cardiovascular disease. And that, of course, as we know, the cardiovascular disease is both, as you may sort of elucidate, Lisa, in a moment, related to our diet, but so is actually psychological well-being, which also obviously leads to erection problems. So very complex topic.
Wow, 4%. That's quite shocking, isn't it? And you just highlighted how this problem is so much more complex than we think. And Lisa, what do you see in your clinic when men come in? Do you see actually couples come to you for advice, or is it more women and then you encourage the woman to bring in the partner?
Yeah, I was surprised that, the number of men that do attend the appointments with the woman. And the majority of the people I see is unexplained infertility. So they've had all the tests and everything's fine, but they're still not conceiving. And as Ulrich said, there are so many factors involved. It's not just diet. So we don't just focus on improving the nutrition. There's lots of other factors as well. So stress is a huge factor that I think a lot of people underestimate, because when you're really stressed, there's lots of knock-on factors as well. So you don't sleep. It can affect your sleep quality, it can affect your food choices, it can affect whether you want to exercise or not, it can affect your relationship, you can lose your libido, and there are environmental factors as well. So you're looking at household cleaning products and the residues on your food, so making sure that you're washing them really well. There's environmental pollutants. There's lots of factors that need to be considered, and that's the beauty of lifestyle medicine, isn't it? We don't just focus on one thing, we incorporate everything.
Mm-hmm. 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 So if you
Sarah, and as a dietitian, Lisa, what kind of nutritional advice do you talk about in your clinics with these couples?
Gosh, there's a lot. I won't talk about it all, because we would literally be here all day. But as you know, I'm a plant-based dietitian and I work for Plant-Based Health Online. So people know when they come to see me that we are going to be talking about the benefits of plant-based nutrition. But at the same time, it's not realistic for me to say to someone who has a high meat content in their diet, or dairy or eggs, to suddenly say, right, overnight you have to go plant-based, because that won't happen. It's not realistic, and it's more of a gradual change for a lot of people. And there needs to be that understanding, because what we want is sustainable long-term change, and not to make the changes too quickly. But there are so many specific nutrients in the diet that is so important. And again, a lot of them are spoken about in terms of maternal health and the health of the baby, but they're not really spoken about in terms of male health. So one would be folate and folic acid. So that's well known, you know, when you're trying to conceive as a woman, and for the first 12 weeks of pregnancy, you need to be taking a folic acid supplement and having dietary folate. But actually it's involved in the whole process of the egg maturation as well. So it takes around 90 days for the egg to mature. So folate during that time is really important, but also for the man, it's needed to synthesize the DNA in the sperm. So it's really important for the man to be having adequate intakes of folate as well. And I wouldn't go so far as to say they need to take a folic acid supplement, but certainly, you know, looking at their diet and seeing where they can increase the folate. And another one is zinc. And for women, it's involved in hormone regulation and ovulation. But for the male, it's needed as well. It's important for the sperm development and the motility. And actually, men's requirements are higher than women's because they lose the zinc in each ejaculate. So they need to have even more zinc than the woman does. So that, you know, as long as they're having whole grains, and I encourage them to have a portion of seeds every day. So whether that be in their breakfast, they can sprinkle it on their porridge or their cereal or their overnight oats. They can put it on avocado on toast. They can, you know, that you, however you want to take the seeds, then make sure that you're having those, especially sesame seeds as well. They're a really good source of zinc. And there's B12 as well. That's really important. And for those on a plant-based diet, you should be taking a B12 supplement anyway, but it's also really important in terms of fertility for both the man and the woman. So in women, deficiency has been linked to subfertility, and for men, it's really important for the sperm quality and the DNA in that sperm as well.
Mm-hmm. Mm-hmm. What do you think happened the last 30 years to
I think it's a
change?
I think it must be environmental toxins. See, for example, if I may stick with this fish example, because it explains it very well. Mm-hmm. See, what we used to eat was sort of wild caught fish. And we used to have clean water, right? And people still dream that when they buy the fish, and they are fooled by label wild caught. And if you actually looked at studies where they actually examined, is this fish really wild caught or not, they actually found that 9 out of 10 are not actually wild caught. They're actually farmed fish. So what happens with farmed fish? Farmed fish gets fed bycatch. So that means other fish which wasn't meant to be caught in the fishing industry gets caught and gets shredded. So that means the PCBs and the heavy metals and the microplastics, the phthalates, they all get enriched as you go up the food chain. So therefore you have these very toxic substances enriched more and more. And then you have the acarxanthin, which is sort of coloring the salmon because it's no longer colored naturally, because it's actually not swimming in the wild sea, because it's actually not eating the algae. And the only benefit of fish was ever the omega-3. But actually, they don't contain omega-3 anymore, the farm fish. And the farmer has to actually pour algae shredded into the farmed fish pots to get the omega-3 into the fish. But they only get a very small percentage in comparison to previous days. And therein lies another big problem then for male fertility, because you must have omega-3 for the membrane stability and for the sperm to be able to penetrate into the egg. You must have omega-3. And you know all that omega-3 and omega-6 are competing. So with a high content of processed foods and meat and animal products and dairy products, we have very high omega-6. Then if you have very low omega-3, that's always going out in favor of omega-6 because that takes the enzyme first. Mm-hmm. So therefore we have here a situation where we have a product which is highly laden with toxic products like microplastic, heavy metal, PCBs, phthalates, and all these sort of substances, and a very low abnormal content of omega-3. So the whole benefit of eating fish has completely gone out the window. And the sperm gets all these sort of damaging substances. And that's probably why we're looking at a 4% normal forms rate now, rather than 15%, which was only as recent as 30 years ago. And there's many sort of people who are actually predicting if we continue the status quo, mankind probably will die out or self-regulated self-love, other people prefer to say, by this factor, by male infertility. So that's one of the strongest reasons why men should stop eating animal products, is also the toxins. But the other strong reasons, of course, the vascular damage. You know, I already alluded that very slightly there with that example of that couple which came to me where he presented with infertility, with erection problems. But that, of course, is a very high saturated fat diet has these two problems. One is the erection problem in the first case, and the second one, of course, the cardiovascular fitness then of that person. So even if they were able to get an erection, they probably wouldn't be able to exercise with, for want of a better term, which intercourse obviously is. So it's a very high sort of demand on the cardiovascular system at the best of times. And many men in jest so say that they would prefer to go when they have intercourse. But you obviously wouldn't want to go too early in your life if you can avoid it. So that is obviously the other strong reason for men to avoid animal products, that they keep their blood vessels in the best shape. Because obviously the high saturated fatty acid, high cholesterol is a prime damaging factor to the blood vessels, combined with high anti-inflammatory products, which we get from the dysbiosis that lead me to some of the stress, which we come to in a moment as well, but also dysbiosis, obviously due to animal products, these bad bacteria, for want of a better word. There's only a word for the good bacteria, the probiotic, but there's no word for the bad bacteria. So these bad bacteria, they will unfortunately produce glucopolysaccharides, they produce TMAO, and they damage our blood vessels, and the finest blood vessels we have on our genitals. As Patrick McOwen had correctly said in his talk a few while ago, a man should wake up with an erection and a woman should wake up aroused, because the blood vessels should be at their prime after a good night's sleep. So therefore there should be very, very good flow. And obviously the blood vessels are damaged, these vessels are not functioning.
Mm-hmm. Mm-hmm.
You've mentioned animal products, Ulrich, and I know studies have shown that men who eat, for example, men who eat cheese regularly have lower sperm count and poorer quality of sperm. And also in women, fertility naturally reduces with age, but the rate of decline is actually very variable worldwide, depending on the local diet. And for example, in Thailand, where they have very little dairy consumption, the rate of decline from the age of 30 to 40 is about, I think, 26%, something like that. And in Finland, where their dairy consumption per capita is about 30 times that of Thailand, the Thailand population, the rate of decline, I think, it's much higher. And from the age of 30 to 40, their fertility declines by about 80%. So that is 78%, something like that. And that is a huge difference. Lisa or Ulrich, would you be able to sort of expand a little bit on why, why that is, and how dairy or animal products contribute to the decline in fertility in both men and women?
And that's a very, very good point you're making there. And if I may take that, Lisa, is that okay with you? If I take that,
something at the end if you don't cover it.
Absolutely.
Perfect. Let's see if I can come up with something. So there's a few factors which are sort of dairy, as you correctly mentioned. There's lactulose in dairy, and that gets produced into galactose, and that unfortunately seems to be directly damaging to the ovaries. And there is a link with ovarian cancer there as well. So you can imagine if that's a strong pro-oxidant, that obviously the cell damage can lead to both cervical cancer and indeed to ovarian decline. And yes, you're very right. We in medical school, as physicians in training, and indeed in our training with the Royal College of Obstetricians and Gynecologists, we just get told, yes, just that's how it is. Yeah. The ovaries just decline like this. And we are not even told this fact you very kindly alluded to, Erica, and thank you so much for pointing that out, that there is actually a difference in different countries. That's not told to us or to our patients, right? So we just presume this is inevitable, and there's nothing you can do about it. And I would very strongly argue with my patients that that is not inevitable, and that when we measure the ovarian function with the anti-Müllerian hormone, that I have seen patients who had a low anti-Müllerian hormone, and we have put them on an anti-inflammatory whole food plant-based diet, that actually the anti-Müllerian hormone actually has at least not decreased, if improved. The other factor why animal products are so bad for the ovaries, is because the advanced glycation end products, which are sort of a byproduct when you heat any animal product, any animal protein. It reacts with the sugars in the blood, and that leads us into the insulin resistance as well via a backdoor again, where the fats come back into the equation. And these advanced glycation end products, again, would be very strong pro-oxidants. They tag on to the RAGE receptor and directly sort of destroy ovarian tissue and lead to ovarian decline. So that'd be the main two factors.
Yeah, and with those advanced glycation end products or AGEs, there's actually receptors in the uterus and as I said, around the ovaries. And it's been shown that in overweight women, if they attach to the receptors in the uterus, they can actually cause that much inflammation that it can stop the egg from implanting. And if they accumulate around the ovarian follicle, it can cause early ovarian aging. So they're really damaging, and women with polycystic ovaries have been shown to have high levels of AGEs circulating. And also in men, they do damage to the DNA in the sperm and the sperm quality as well.
Yeah.
And it's when you cook meat, and as I said, the brown layer that forms on the meat, so if you're barbecuing or frying or even grilling, that brown layer that forms is the AGEs forming. So meat is the highest sources of AGEs, but you can also get them in a plant-based diet as well. So for example, nuts, you want to avoid roasted nuts and choose nuts in their natural unsalted form, because they're much, much lower. And even when you toast your bread, the brown layer on the toast is the AGEs forming. So I always advise my patients who are trying to conceive to avoid toast if they can, and to just have the bread.
That's correct, but luckily one can say that with any plant product, it's still much less AGEs you get than with any animal product. I think that's very important to make that point. So even if you're a bad cook and you burn your vegetables, you still haven't done as much damage than if you put your meat on the grill. That's for sure. To point that out. Yeah.
And Lisa, you mentioned about plants and adding as much as you can. Can you tell us about the fiber in the plants and how does it affect the estrogen levels? Is there a link between the two?
Yeah, I mean, fiber is hugely important, and when you have fiber, and it's important to have a variety of fiber as well. So it's not just fiber coming from one plant, but everything. So whole grains and nuts and seeds and fruit and vegetables and lentils and every part of a plant-based diet. And it's not just important for balancing hormones and fertility, but it's important for everything in your body. And the gut is central to health. It's incredible. It's strongly linked to the immune system. So 70% of your immune system is in your gut. 95% of your serotonin is produced in your gut and not your brain. So that's, there's that huge connection to the brain and mood as well. So obviously that's all plays a role in fertility as well, because when you're low in mood, you suffer with anxiety, depression, that can impact on fertility. And standard Western diets are low in fiber and high in saturated fat and these AGEs. And there can be a knock-on effect on a protein in your body called sex hormone binding globulin. And these proteins, they do as they say, really, they bind with the sex hormones and they stop them from going haywire in your body. So they hold on to them until they're needed, and then they're released. So for women who are overweight as well, they don't have as many of these proteins in the body, and that's what can cause the hormones to go crazy, and the symptoms of polycystic ovaries, and also endometriosis, because that's a hormone-driven inflammatory condition as well. So as the UK, a general population, we're probably having about 18 grams of fibre a day maximum. So of course, a lot of people will be having a lot lower than that. So fibre is hugely important to have in your diet.
Mm-hmm. Mm-hmm.
And the ideal amount of fibre that we should be having in our diet should be?
Well, we should be having 30 grams of fibre minimum, really, but people don't really know what that looks like. So as long as you're having a variety of different plant foods every day, then you'll be meeting your fibre needs.
Mm-hmm. Mm-hmm. And interestingly, when we are looking at the whole holistically, the patient and the lifestyle, Harvard research have found that when we look at exercise, that walking doesn't improve fertility, but vigorous exercise does. On the other hand, like cycling, swimming, jogging, were shown to reduce the risk of fertility even in women with the same body weight. Ulrich, you advise them to exercise regularly and to incorporate a de-stressing activity when they are looking for fertility treatment?
Absolutely, I definitely would, and I sort of obviously with exercise can be careful. You have to be careful that you do the useful amount, and the useful amount is first it has to be regular. Often women say to me, "Oh well, I go twice in a week to a class." Mm-hmm. That's actually stress because your body is not used to it, mm-hmm. and it actually has a detrimental effect. Whereas if you do much less exercise, but do it every day, at least 5 out of 7, your body actually gets used to it, and it actually does have the positive effect on the insulin resistance and indeed on the stress, lowering the stress. So I think that's very important that women understand, and men as well, of course, for their own hormone balance and their insulin resistance, what the right amount of exercise is. So I would go with WHO guidelines or with the RCUD guidelines that we're aiming for around 30 minutes strenuous exercise 5 out of 7 days a week. And the sad thing is actually that many couples come back to me when they've been to the fertility center. They, I've been told not to exercise at all.
Oh.
And I said, why is that? There's no evidence for that to reduce exercise, but there seems to be a fear among some health professionals that exercise may be a problem for fertility, but nothing could be further from the truth.
Mm-hmm.
Yeah, and I think we have to be slightly careful how we interpret that study because it wasn't a big study, and we have to bear in mind that vigorous exercise can increase our cortisol levels, and that's not that's not great for female fertility.
Exactly.
Either. So we have to, I would always recommend moderate exercise where you can hold a conversation but still be slightly out of breath and not do anything that's too vigorous. And also we have to be careful with men, don't we, with cycling, because men who do a lot of cycling, that could affect the sperm as well, because of I guess it's the heat of the saddle and being kind of squashed around that area. So yeah, we have to be careful there. And also, of course, if women are doing a lot of vigorous exercise a lot of the time, they're more likely to be a lower body weight, have lower percentage of body fat, and we need a certain percentage of body fat to be able to conceive as well. It plays such an important role.
There is actually a question in the chat about for men cycling and running. Do they reduce sperm count? So you've mentioned cycling. Is that the same with running?
I haven't heard it in terms of running. I think it's just anything where that area gets very hot, or if it's squashed into tight pants or anything like that, then that can negatively affect it. But running in specifically, I haven't heard.
Mm-hmm. Mm-hmm.
Yeah, I wonder if it's all a bit sort of blown out of proportion, this whole exercise thing. I think it's just a distractor. There's a distractor from the real cause of male infertility. yes, there's a few men who generally have temperature problems, and those are those ones with a varicose seal, right? So it's very important to actually examine the man as well, actually have a look at the testes, measure the size of the testes, have a look at the blood vessels, have a look at the varicose veins. And back home in Germany, when we ran an infertility clinic, the man would always be part of the clinical examination and would have his own examination, all that. And here in Ireland, I don't know how it is in the UK, but we do seem to neglect that part a bit, and the men are not really examined at all. But I think there is some benefit in those sort of factors. So if there's genuine varicocele, then one could argue maybe the testes are more likely to be too hot in this man. And yes, you're right, there's some extremes where men have the regular hot baths because they were told by their mothers to do so every day. And those are extremes, but the vast majority is probably more a distractor. And I think environmental factors are probably stronger, really.
Mm-hmm. Lisa, you mentioned about body fat earlier. So I remember sitting in a fertility clinic when I was on my obs and gynae placement a couple of years ago. You know, people's BMI was often talked about, and I think there is a threshold for eligibility criteria for fertility treatment, depending on, you know, it varies region to region, I think. And so what is the ideal BMI in people who want to conceive, and why is that?
So, I mean, the healthy BMI range is anything from around 19 to 25, and studies tend to go more towards the heavier side, so around 24, a BMI of around 24. But you know, it's important to be as healthy a weight as you can be before you try and conceive and before you fall pregnant. But women who are overweight have shown to be, and obese especially, are 3 times more likely to struggle with getting pregnant. And what women don't know is that, you know, don't really know, is that they're, oh yeah.
Wow.
Is that from, what book's that from?
It's from...
Oh, right, yes. Yeah.
I won't show mine.
What women don't really know is that there is support during the preconception period. It's in the NICE guidelines to help them to lose weight. And not many women access that support because, well, they don't know it's there. There can be lots of barriers to it. I think sometimes health professionals can be a little bit insensitive when talking about weight as well. It's really important to you know, to be non-judgmental and to allow the woman to talk about their weight and maybe not just assume that they want to talk about their weight, and to try and help them to achieve a more healthy weight. And even weight loss of 5% has been shown to be beneficial. Sorry, Ulrich, did you want to jump in?
Well, whenever you're finished, I don't want to interrupt you. That's why I'm just raising my hand.
No, go on.
But I think the trouble is why people are so sensitive on the weight issue, because the weight is not calories in, calories used. It's not that.
Oh, it's far more complicated than that.
It's far more complicated, and it's a bit like addiction as well. There's some reason why this woman is overweight or this person is overweight, right? And the vast majority in the gynecology field, I would say, is that there was previous trauma.
Well,
and the trauma
is huge.
And the trauma then leads to chronic stress. And the chronic stress then leads to a high glucocorticoid and leads to dysbiosis. And them two together make you then a super food processor. That means you have X amount of calories. And if that other person here beside me has the same diet, he or she be fine as a normal weight. But this person who's traumatized, her weight or his weight shoots up because the glucocorticoids are high, and because there's dysbiosis in the gut. And I think that's very, very important that we are cognizant of the fact. I don't know if I can, oh, you've disabled the screen sharing. Sure, look. I would have shown you a nice graph otherwise. It would have been lovely. But sure, look.
We can add you and you can share the graph now, I think.
Let's see now. Can you see that there, guys?
Mm-hmm.
Yeah.
Can you see that chronic stress graphs there?
Mm-hmm.
Yeah. See that there? So there's acute stress there. See, can you see my mouse wandering under the screen? Yeah.
Mm-hmm.
So the acute stress is not such a bad thing, and the acute stress obviously wants us to get ready to run away or whatever, right? So mostly would have been run away from a predator. So that's what the acute stress does. So it goes under the pituitary, adrenal glands, gives us glucocorticoids, gives us glucolysis, lipolysis, to get us ready to run. But as you can see, there's a nice feedback loop, okay? So that this doesn't go out of kilter with the acute stress. So that's all nice and lovely. But these people have suffered chronic stress. So that means it goes here from the amygdala, from the anterior pituitary, adrenal glands, glucocorticosteroids are too heavy, the signaling is impaired, the homeostatic regulation goes haywire, then you have insulin resistance, dyslipidemia, atherosclerosis, hypertension, peripheral inflammation, all these. And then this leads then to an amyloidogenic pathway induction, which actually leads to Alzheimer's disease in the long run, right? Tau phosphorylation, exotoxicity, oxidative stress, learning memory deficits. So that means for this person becomes more and more difficult now to actually deal with her stress because her brain is actually becoming damaged. So whatever you're trying to do now in this chronic stress situation is very much more difficult to actually get down to the person because the brain is actually getting inflamed and will in the long run be damaged. And I think it's very, very important that we appreciate that. And I have many of my patients have now BMIs of 40, 45, and you see them in the A&E because of chronic pelvic pain. And they come again and again, and you find often then a cyst or whatever, but the cyst is only another expression of the dyslipidemia because they have insulin resistance from that, and therefore obviously their cycle, as you can see here in this diagram, reproduction is shut down, one of the first things. So obviously the cycle is not working regularly. So obviously they're getting a large follicle, which then the surgical colleagues are only too happy to turf her to gynecology and say she has a cyst. And we're only too glad to take her, because we know that this trauma is at the bottom of this all. And when eventually at the 10th visit, the woman is ready to reveal, yes, there was a severe trauma, then we can finally work on that. And I've put that up here now. Hold on, can you see this now, this slide?
Mm-hmm.
We are now starting to screen for adverse childhood events. At least we are starting this in the rooms, and hopefully we can do that in the public clinic as well very soon, because we do find that the more symptoms a woman has accumulated, and obviously obesity is just one of these symptoms, the more likely she is to have suffered 1 or 2 or 3 or 4 of these. And once you're above 3 or above, you can expect that this is quite a severe influence on your lifestyle, you know. And I think it's unfair then to say to a woman who's overweight, well, you're just eating too much. Mm-hmm. And that's, of course, why she's crying if you only have the closest resemblance of even mentioning that. And I admit that I, as a junior doctor, you know, I was falling into the trap, and that I probably wasn't kind enough, as one should have been in this situation. And I was ignoring these corrections. And now only in the late 50s, you finally realize, oh, well, you know, there's obviously more going on. But I think we have to acknowledge it's not just food, and it's just not stress. But it's the two together which we both have to address, and to help these women genuinely.
You often need a whole multidisciplinary team approach when it comes to helping women, you know, who would like to lose weight. And
but that's right. But the problem is the woman ready? Mm-hmm. That's the problem. And that's where this psychological reversal comes in, where people may not be ready to sort of change because they may have secondary benefit syndrome, because whatever problem they're trapped in, it may actually give them secondary benefit syndrome, where you have, for example, here you have disorders, you get some advantage due to that, to this illness behavior, or you want to punish somebody due to that. So all these things are playing into that. It's very complex.
Very complex.
How do I stop sharing my screen now here? Yeah. There we go.
Well, I think it's also important to say there in terms of weight as well, that a lot of women are told to go on low carbohydrate diets. And I've seen that fertility clinics, it quite commonly happens there that they're told to go on a low carbohydrate diet. And actually that's the worst thing you can do to try and optimize your fertility.
And Lisa, can you elaborate on this carbohydrate diet? Because I think we use this word carbohydrates quite loosely, don't we? We have carbohydrates, that's an Oreo cookie, and then we have a carbohydrate that is an apple. Both are carbohydrates. One of them is full with trans fats, and the other one is full with fiber and food for our good microbiome, right? So could you just elaborate on that whenever we use this term carbohydrates, and what should a patient be looking for when they are actually advised to go on a good carbohydrate diet?
Yeah, you're right. So they just get lumped all together as one, and they're not all equal. They're very, very different. And if someone has someone has a diet that's full of refined carbohydrates, so that's things like white pasta, white rice, white bread, processed foods, then yes, we're going to advise that they reduce their intake of those things. I'm not saying they have to cut them out altogether, but just reduce them down significantly and replace them instead with whole grains. So whole grains are brown rice, black rice, red rice, whole wheat pasta, quinoa, barley, spelt, everything, all kinds of grains. And actually it's really, really important to have a source of whole grain with everything that you eat, because not only are they full of nutrients, so you've got micronutrients and minerals in there and all that all important fiber, but your body needs them. Your body needs carbohydrates, whole grains for energy. It's the only thing really that your brain can use. If you don't have enough of them, you're going to feel tired and irritable, and you're just not going to function properly. And fiber is so important for hormone balance, and especially in polycystic ovaries, when you have insulin resistance, the two main arms of treatment are weight management and blood glucose control. And by having the whole grains, they're released a lot more slowly. They can help stabilize your blood glucose levels and keep them at a steady rate. Whereas if you have the refined carbohydrates and a lot of added sugar in your diet, then you're going to get the big spike and then the big fall. And that's not going to help at all. So if anyone has been advised to go on a low carbohydrate diet, please don't. Reduce your refined ones by all means, but make sure you're having plenty of fruit and vegetables and a source of whole grains with every meal.
And I would like to add this to the diabetics as well. Just I see more and more patients who are being advised that they shouldn't be eating fruits and vegetables. Yesterday, I just had a patient which broke my heart. She told her doctor that, she snacks during work because she has a 12-hour work day. So she actually eats apples, bananas, and fresh vegetables as a snack during the day. And she was actually asked to stop eating those things because it will increase their sugar levels. And she's not even insulin dependent. But I think there's some kind of a weird agenda going on here against healthy fruits and vegetables that has been perpetuated by our culture. Have you seen that as well in your practice?
It's a lack of understanding, I think, because fruits contain fruit sugars, they contain fructose, but they also contain fiber and phytochemicals and micronutrients, and it's all packaged in one matrix. And when you eat the whole fruit, it doesn't have the same effect on your blood sugars as if you were having a glass of fruit juice, or if you're breaking down that matrix and having a smoothie where if you're using a NutriBullet or something like that, you're breaking it down, but the fiber's still there, the skin is still there, everything's still there. But if you're making a juice, then that's, I wouldn't advise that, because that's going to take a direct hit on your blood glucose levels. So whole fruit and vegetables, definitely should be including them in your diet.
Yeah, absolutely. I'm glad we cleared that up from a dietitian. Thank you. Yes, Ulrich.
May I just add a few pointers on that, and thank you so much, Lisa, for pointing that out. I think you're very right with the whole grains, and one other important point is the circulation of hormones. Mm-hmm. Our hormones get produced as many things in nature in excess. And what is too much, as you correctly say, will be bound up by SHBG, by sexual hormone binding globulin, which is sort of the aircraft carrier, so to speak, and that gets regulated by androgens. And it gets actually pooped out. But if you have only a bowel motion every 3 to 4 days, as most of my patients only have, then obviously you're not discharging this excess hormone, and it gets recycled, which normally is a good thing, but in this context, recycling is not a good thing. So that means you get reabsorbing the same estrogen again and again and again, and it has again and again an effect on your on the endometrial lining particularly, which then get thicker and thicker, and you may end up with a situation where you have endometrial hyperplasia and where you may have precancerous lesions like intraepithelial endometrial lesions. And of course, you're ending up with infertility from an implantation point of view. And of course, you're producing excess prostacyclins in the excessively thickened endometrium there. So it's very, very important to be aware of this other beneficial side effect of fiber, that it helps in the recycling, it helps reducing the recycling of hormones. And the other thing, of course, is with whole grains, or any fiber at all, really, that they feed our good bacteria, our probiotics. The funny thing is most patients actually are aware of this word probiotics, and they're actually even taking a probiotic. But I always say to them, listen, guys, it's like as if you're taking a pet in, right? So you're bringing a pet home, but you're not feeding it. So what good is that going to be? The pet is going to die on you, right? So if you're taking probiotics, you need to feed it. And the only foods they like is fiber. And if you're having your white bread there with ham and cheese on it, that's not going to feed your pet, right? So you need to have your whole grain, your brown rice, your brown pasta, and your wholemeal bread, and you feed them. And then they produce for you what we call the postbiotics, which are the short-chain fatty acids, which repair your gut lining nicely and therefore stop the inflammation and therefore stop the whole process of arteriovascular disease. But also they produce your feel-good hormones, like the gabapentin, the serotonin, and the dopamine, which all then in turn help your stress levels to come down, and then in turn hopefully help you again with this whole cortisol release that we discussed earlier. So yes, I agree with you entirely, Lisa. We cannot underestimate or undersell the importance of high fiber diet. Yeah. Mm-hmm. That's what we're all deficient in. We're all deficient in fiber. But yes, if you ask any patient what they're eating protein supplement. And nothing could be more detrimental to their poor kidneys and livers.
I think it's so important to start painting the picture that fiber is best in food, whole foods, plants, and as Lisa said, in grains, wheats, that are as little processed as possible, because not only do you get the fiber that, yes, you could get from a package, not a good quality one, but you're also getting what's attached to that fiber, what's missing in our health right now. All of the zinc that you mentioned, the magnesium, the folic acid is not attached to the fiber that is in our little package, increasing your natural source of fiber, which is in whole foods and plants.
You're very right. And I would even be more extreme than Lisa was just saying there. About the natural context. There was a fantastic study there where they gave people 2 apples, right? So this group got 2 apples, and the other group just got the apple cut in pieces.
Okay.
And the group where they had the whole apple just biting into it, that lowered their blood pressure. And the other group where the apple was just cut up, right? It didn't have the effect. So it shows you that as little processing as possible is for the best for the fiber and for the natural context. To have all the phytonutrients and micro minerals and all this are working in unison and not disturb each other. And I must admit that I've done full circle. You know, when people ask me about natural treatment 20 years ago, I said, sure, look, you're not a plant, you know. And now I have to admit that this has completely changed. And we are now appreciating that nature has actually put this all together for a reason, because it only works together. You know, and even by shredding it, by juicing it, you're robbing it of its natural context.
I just saw a question pop up then about Weetabix. Someone asked if Weetabix was bad, and I don't have a problem with Weetabix. They're fortified for a start, so they can be useful in terms of you know, feeding children as well, or plant-based children, and they're actually pretty low in sugar. And if you're going to have Weetabix, then, or you're going to have breakfast cereals, then they're probably one of the best ones to go for. So definitely don't think the Weetabix are bad.
It's not.
I saw what you go for.
It's just the only thing that comes to people's mind because of good marketing is Weetabix. This is the problem, is the marketing brainwashing that Weetabix is fiber and nothing else, or these packages. I mean, this is what I'm picking up from the conversations that I'm having. And also that we could go one step better than Weetabix. Why not actually cook the grains at home that we do? I can kind of cook 3-4 grains at home, put it in the fridge, and then you have the grains cooked. You can mix it up with the same way as you eat your Weetabix, with cinnamon on top and a bit of oat milk to mix it with, and then you have the real grain. So just go back to the basics and not just being fed the marketing idea of these products that are in boxed up versions. But Lisa, you guys opened an amazing clinic, the Plant-Based Health Online. It's one of the first clinics in the UK. I would like to congratulate you and your team and Dr. Laura Freeman. And yeah, fantastic job. And Dr. Shireen Kassam, who is the leader of the plant-based health professionals, who is just doing a sterling job. All of you have done an incredible job bringing this clinic together. And I think why it's so amazing is because you really are looking at the whole of the person. And that's what we are talking about here on Afternoon Tea, to finally look at the person as a whole, from exercise, nutrition, from a doctor's perspective, what we are good at, and combine that with a multidisciplinary approach. So tell us a little bit more about how do you approach a patient in this utopian way of treating?
Well, first of all, I'd just like to say I'm so happy to be a part of the team. It really is an incredible team, and we're all just as passionate as each other about helping our patients to feel better. And I think it's important to say that it's not just a health service for vegans or for people who are already plant-based. You know, and anyone is welcome to come and have a consultation with us. And our aim is to treat patients primarily with diet and lifestyle interventions. And of course, if they need any medical treatment as well, we will, you know, we work alongside that as well. So it's not an alternative health service, but primarily we are looking at diet and lifestyle. So it's a completely non-judgmental, open service for anyone to come and see us. And it could be anyone, ranging from someone who just wants to feel a bit healthier and wants to transition to a more plant-based diet, to someone who has a chronic disease like diabetes or cardiovascular disease, infertility, someone who has raised cholesterol. You know, there's a huge range of conditions and patient types that we see.
Absolutely. It's for anyone, I would say, who is actually wanting to address those core causes of disease. So chronic diseases are on the rise. 80% of the deaths could be prevented, treated, and causes have to be looked at as a whole with a compassionate multidisciplinary team. Otherwise, we are going to continue the rise of the pandemic of chronic diseases. And that's why it's so good that you guys finally brought this approach to our patients. So really salute you, and to our listeners, if you are interested in looking at your health as a whole, we'll put a link in the chat.
Plantbasedhealthonline.com.
We'll put that in the link. We are not sponsored. As you guys know, everything is non-sponsored here. We just believe that it's time to stop chronic diseases, and this is the way to do it. So yeah, bravo, well done.
Thank you.
I'll also drop a link in the chat of the wonderful fact sheet that you have created, Lisa, for health professionals. So I'll drop that in the chat on diet, lifestyle, and fertility for anyone who is interested. And there is information on male and female fertility there, and general lifestyle advice, and it's a brilliant fact sheet, so have a look.
I'd like to highlight anything more that you have been seeing in your clinic that you think is so important to have a look at.
Another issue which is very important and is not mentioned at all is actually non-steroidals. And I went to a pharmacy the other day, and there was a queue of women in front of me. That was before the lockdown. And I was amazed the amount of painkillers these women bought over the counter. And then the pharmacist rightly so said, "This is too much. This is above the allowance I'm allowed to give you." And she said, "Oh, I'm buying for Lisa and John and Caroline and whatever." So she had 5 different names she was allegedly buying these for as well to get more supply. And that wasn't the only one. Every single one in this queue was buying enormous amount of non-steroidal painkiller and anti-inflammatories. And the truth is, you see, these guys, they're COX-2 and inhibitors. And they may have sort of effects on fertility. Right, because they're important in the generation of prostaglandins that are essential for the formation of proteolytic enzymes, which cause the rupture of the egg follicle.
Right.
So if you suppress those guys, then this is not happening. Right, so your follicle is not rupturing, and there's actually a very interesting study there, which actually has shown that if you sort of take regularly ibuprofen and all these other things, which many women do, you know, for sort of chronic pelvic pain, then you have only 1/4 of the chance of ovulating than those who don't take it. And I think it's just one little nugget which I wanted to share in this group, because I think very few of us may actually think about that, to ask that in the history. How much are these women actually taking?
I don't think we would ever consider it. Instead, we would just prescribe it. Or advise you to take it.
But exactly. You may even prescribe it in the consultation where the woman comes with infertility issues, because she mentions it in the sideline as well. And I think it's just very important to highlight this, that this is a very important issue. Another issue to sort of mention is thyroid, to just make sure that the thyroid is running perfectly. And you know the normal ranges we have for TSH and for T4. The truth is that these ranges are sort of not taking cognizance of the fine hormone balance you need for ovulation to run perfectly. But as we've just learned, reproduction is one of the first things to go if there's stress, because you obviously only want to have a child when you're safe and when everything is perfect. Right, so the reproduction is always the first thing to go. So therefore, if the thyroid is a tiny bit off balance, so the TSH is just a bit too high, that may be enough for the thyroid to be subclinical low, and therefore that may be producing excessive prolactin, which also goes up with stress, actually, with many other medication too. And that may be enough then to inhibit ovulation. So therefore, it's very important to be cognizant of the fact that the thyroid has to be running perfectly, and we are aiming for a TSH level which is often the mid-range of the normal range, which is just 2.5, whereas the normal range for most labs will go up to 4.8. So just another little nugget to sort of share with the audience here.
how is a gynecologist going to have a look at that patient? And are they going to advise them to get their thyroid function test, get their nutrition under control, get their stress under control? Do you think that ever happens within the NHS or in the system, in the global health system that we are living in?
The frustrating thing is that if a person gets referred to an NHS or HSE here in Ireland, standard infertility clinic or standard infertility outpatients, right? Yes, they would get the hormone test in fairness. They may or may not get the anti-Mullerian hormone done, which is a very important hormone because this is produced by the follicles and it will be too low if your ovarian function is already suffering, if your ovaries have been damaged. And will be too high if you have polycystic ovaries. So a very important marker, which I would always make sure gets taken. But it wouldn't be necessarily standard to be taken in every clinic because it's quite expensive to do. And then, yes, thyroid would be included in most teams. I would give them that, and prolactin, hopefully they measure as well. And high prolactin, of course, is a very tricky one as well because it goes often up by stress. And just the fact that you're going to an infertility clinic and the fact that you have blood being taken may already be enough stress to be artificially high. And then, but then it often will falter, I'd say, with a lipid profile, right? And I must admit, 10 years ago, I wouldn't have taken a lipid profile for an infertility patient. Now I always do, right? Mm-hmm. And now I appreciate how important this is in the whole polycystic ovary context. If you're lucky, then the team might be taking this male hormone factors, the testosterone, the free androgen index, and the SHBG. But again, you may not be lucky enough, and these may not be taken, right? So there is quite a few gaps there in the training of the junior staff, and obviously I'm trying to make sure that my team gets sort of acknowledges these sort of gaps there. And then we move on, of course, to the examination. And yes, you're very right. Of course, you wouldn't have both spouses there and have to examine them both. But as you correctly say, often it's just the woman who presents initially. And that may be, well, just a testing visit as well, you know. And then it's very important to examine them and to ask actually a proper story to see what has happened so far, what is the real history. And when I was having a few slides, and it's actually one of my slides was actually coming together, and we've seen the most surprising thing. That people don't know how to have intercourse, and they would use the wrong route of access and would be surprised. And obviously you have to be open and frank and actually discuss this. Are you actually doing the right thing? So maybe as simple as that in the very easiest cases. And then there's other couples here, particularly in the west of Ireland, who wouldn't have intercourse because the church would condemn it as being dirty. And they wouldn't even entertain such a sort of getting, you know, getting ready for intercourse. So one has to be starting at very, very simple things sometimes and has to outrule or has to work at very sort of tabooist concepts which have been ingrained in society, either to society or indeed to trauma. Mm-hmm. So I may have to work on these. Mm. So that would be sort of the coming together of the spouses. But then, of course, the coming together, as we were saying earlier, erection problems and arousal problems may be a big problem as well. And then, of course, if a woman doesn't have an orgasm, the sperm is not sort of being taken up into the uterus and may not do its further journey. So these are all very important things. And many women here in the west of Ireland and probably in the UK as well, because of the tabooist culture, they may never have an orgasm at all. Because they're having this sort of ancient perceptions, or they haven't been talked about really, or they perceive it from social media or whatever as something negative to start with, and would just endure it for getting pregnant, but actually never enjoy it. And obviously there'll be a major factor. And so we will be starting sort of with history taking of trying to tease out those factors, how these things are, you know, and before we even start with the examination. And then with the examination, of course, it can be very simple things. You know, there can be sort of, there can be blockages. The blockages can be in the hymen. The blockages can be in the cervix. I've seen quite a few patients who had a blocked cervix. And that may be because they had a previous LETS treatment, so long loop excision of the transformation zone for an abnormal smear test. That may be because they had a pelvic inflammatory disease in the past, which has clogged up their cervix for whatever reason. Or they may just naturally have a very closed cervix, which only opens up when they have their period. So often it's very simple things you have to actually look at as well, and sort of examine these things and help them overcome these. And often the blocked cervix is often very simple, and we have an ambulatory gynae clinic where you can actually do an outpatient hysteroscopy and clear those things up on that very sitting where the couple is presenting first. Then, of course, we check for infections as well to make sure there's no pelvic inflammatory disease, because obviously that's then the connecting, can the sperm and egg come together at all? Are the tubes free? But that mostly we leave for a later stage of the journey. Because there could be obviously loads of blockages for the tubes. There could be fibroids, there could be endometriosis, there could be previous pelvic inflammatory disease, there could be previous cesarean sections, there could be previous terminations, there could be previous miscarriages, and there could be previous intrauterine operations, which all may have contributed to a blockage higher up then, which obviously has to be clarified as well.
I'm surprised now that people actually get pregnant.
Well, that's right.
I mean, you know, there's quite a lot going on there. Lisa, when you look at patients now with your incredible multidisciplinary approach, can you tell us how will you approach this question, infertility? So I'm a patient and I come to you, and I have been trying to get pregnant for a while, but I can't. I come to your clinic, and what will be my journey as a patient in your clinic? Who will look after me, and what are the things are we going to discuss?
So, I mean, there's an awful lot to discuss. So I would always look at, you know, the background, what's been leading up to, you know, to the difficulty in conceiving, looking at the diet and lifestyle of both partners, looking at their food diary. So we always ask for an example of what they typically eat in a day, or, you know, over 3 days. And then we look at particular, you know, I'd look at particular aspects of their diet. We've discussed every nutrient that's, you know, important in terms of fertility. We talk about supplements as well, because that's really important. I've had patients come to me who've been advised by their personal trainer at the gym, you know, someone who works in a health shop, to take huge amounts of supplements, costing an absolute fortune, that most of them are completely unnecessary. So we, you know,
and they can cause harm. So the supplements are just like drugs. We cannot get this across more, that if you take a supplement, it might not cause you harm, but it might not help you, but it might cause you harm. So do not subscribe to supplements in large amounts just in case, because they really can, and we have seen quite a lot of side effects of supplements, and liver failure too, where people were so desperate to get the health result they wanted that they have taken a large amount of supplements, which actually cause liver failure, and some people will end up having to have a liver resection or death.
Yeah, so, and that especially, you know, relates to herbal supplements, because most of the time we don't know what's in those herbal supplements that they're being told to take. And iodine is another one. Taking too much iodine can be really damaging, and can not only damage your thyroid, which is pretty serious, but can also negatively affect your fertility as well. So we always have a thorough discussion about supplements, because some of them, you know, you do need to take when you're trying to conceive, and folic acid is one example. But you certainly don't need to be taking, you know, hundreds of different types of supplements. And I think, you know, also people are desperate when they're trying to conceive. And I know that from personal experience. It's the reason why I went into fertility in the first place, because I struggled for years with infertility myself, and had to have IVF to have our youngest son now, who's 2.5. But, you know, you're desperate when you're trying to conceive, and you'll believe anything you're told. You know, you look on the internet, there's lots of people willing to give you advice who don't know what they're talking about. There's lots of influencers on social media giving wrong and frankly quite damaging advice. So it's really important to speak to a health professional who actually knows the evidence base and will give you beneficial, helpful advice, and not advice that is going to harm you.
Absolutely. And Adrian just asked about, is there any situation in fertility where purely plant-based vegan diet may be less advisable, or where we would need to be cautious with it?
I think any diet needs to be well planned. So if you're having a poor quality diet of any type, then you're going to be at risk of certain micronutrients. But a well-planned vegan diet, the British Dietetic Association have come out and said that a well-planned vegan diet is suitable for all ages and any situation. So if you're pregnant, if you're a child, and yes, on a plant-based diet, you have to be more mindful of certain nutrients and to make sure that you're getting enough. For example, calcium, you need to be having fortified milk and yogurts in your diet, as well as a varied nuts and dark leafy veg and dietary things. And you do have to be a little more mindful of certain things, but it's absolutely the best thing to do in terms of your general health as well as your fertility. Because I mean, we've got data saying, showing that women who are taking or who are eating higher amounts of plant foods have better rates of fertility, and you can't argue with that.
And I think people often, just with any conditions, people would ask, what is your specific advice for example, endometriosis or PCOS, or whatever with lung disease. They would be like, is there specific advice for asthma and COPD? But as we know, actually, a lot of these conditions, these chronic conditions, have the same underlying sort of disease process. For example, inflammation is what's driving a lot of these conditions. So actually, with the advice that we, all the things that we have talked about today, like increasing fiber if you can't, go fully vegan, increasing your fiber intake, reducing dairy products and animal products, managing your stress, and managing your sleep, exercising, looking at your relationship with other people. Are you lonely? How is your mental health, your emotional well-being? All of these things, they all tie in together and will tackle the underlying inflammation. And I think that's a really important message to get across to people with regards to any chronic conditions. Yes, Ulrich?
It is. And oh, sorry, go on.
No, you're right.
Well, I was just going to say that the process of trying to get pregnant is stressful in itself, and it puts a lot of pressure on your relationship. And especially if you then have to go through fertility treatment, that increases the pressure as well. So it's really important to put those stress management techniques in place. And there are lots of things you can do. There's meditation and yoga and Pilates, mindfulness, breathing, just positive visualization. I found that so helpful when I was going through fertility treatment myself. Do not underestimate the power of positive visualization, and that's something I always talk to with my patients as well. And I think because I've gone through the process myself, I know how difficult it is, and I can give my own personal tips as well that might not be evidence-based, but they help me, and if it can help other people, then I'm quite happy to share them.
Absolutely. Would you share a few more just to our audience?
Well, you'll probably think this is really funny, but I read a study where laughing helped women after the embryo transfer. So I thought, right, I'm going to find something really funny that I enjoy watching. I'm going to download it onto my phone, and I'm going to watch it on the way home in the car from the fertility clinic. And then when I get home, I'm going to put my legs up in the air on the sofa, and I'm going to laugh for at least 2 hours. So I watched Mickey Flanagan for 3 hours and laughed the entire time. And anything that makes you laugh, you can't feel stressed when you're laughing, can you? Yeah. You feel happy. You've got all those endorphins going on around, and I honestly think that it helps. So that's a little thing that I always share. On your way back from the clinic after having your embryo transfer, find something funny and just laugh.
Oh, that's a beautiful, beautiful advice. And we have evidence behind it, because we know that the meta-inflammation that is caused by stress, you just described in the last hour, what are the crazy side effects that it causes. So doing the opposite, laughing, and in the end of the day, what is the worst side effect from laughing? At least you had a good time, eh?
Exactly.
I think that's amazing advice. And I've forgotten what his colleague's name was, but there was a famous doctor in the US who actually sort of, he was in prison himself with a depression, and then he sort of had a dream to become a doctor, and he did eventually. And he sort of had a skill of being sort of a clown, and he brought that into this hospital. And to this very day, this hospital very much works with that, with laughter as of medicine. So there is a lot of evidence behind that, and that certainly is sort of a good thing. But I just wanted to chip in as well about anti-inflammation, as you correctly said, as most people said, it's all connected. Inflammation is sort of very much sort of on the background of all these diseases. And there was a few questions as well there. Now, I know we're going to come to endometriosis and fibroids in other sessions, but just to say that all these conditions are also based on severe inflammation. And the truth is with inflammation, it's not dose respondents, it's toxic respondents, right? So that means you have any trigger for the inflammation, that's enough to keep it going, because it's immune response, right? And that's the same problem as with smoking as well. It's a toxin. It doesn't matter how much you do or how much you don't, right? So it's important that you avoid it altogether. So that's why I would actually tend to be stricter with my patients, and I would actually say to them, listen, if you really want to have full success, it would be best for you to commit fully. Yeah. So I would be strict with them and say, okay, listen, if you want to go this journey, go whole food, plant-based, and starve out these nasty bacteria out of your gut. Because if you keep feeding them occasionally with animal products once a week, twice a week, they're not going to go away. You want to starve them out. So only if you have no animal products, they will leave you. Mm-hmm. I know this sounds harsh, and some patients may find that, oh gosh, or you have to give them a chance, you have to ease them into all that. But if you actually look at successful changes, they are more likely in the abrupt changes than the slow changes.
So if you do want to conceive and your why is to get pregnant, that's a strong enough why, I think, now to introduce the information that the patient needs to achieve that result. And we can be black and white about it. If you want to achieve it, this is how you do it.
It's also a point of credibility. If you sort of question your own method already and say, oh, well, yeah, sure, you can just do it a bit, you come across less credible. And patients very often ask me as well, are you vegan actually? I said, yes, of course I am, because it would be stupid if I had read all this evidence and don't follow it myself. So there's very, very important credibility that you do what you say yourself and that you fully believe in it. And I think the full belief only comes fully through if you can confirm to the patient, yes, I know this will work if you do it full-hearted. There's no point in you just dabbling around with it.
It's also really important to say that following a whole food plant-based diet is not going to guarantee that you get pregnant. Nothing can
that is true, of course,
that.
Yeah.
We have to say, we have to not give people false hope as well.
No, that's right, yeah.
But also to understand that in an ideal world, that would be amazing. We tell our patients, right, overnight, you've got to go whole food plant-based and that's it. But unfortunately, a lot of people really struggle with it. And I know from my experience with my patients, and if you say to someone who's got a very, very heavy animal product diet, right, you've got to cut that all out now, go whole food plant-based overnight, that's it. They won't do it. They won't do it. And there's only a very minority, a very small group of people who will say, right, that's it. I'm really motivated. I'm going to do it. Unfortunately, it's only a small minority of people. So we have to show understanding and help people to make that transition into a way that it's going to be long-term and it's going to be sustainable for them. And I think men struggle more than women, in my experience, because men tend to be heavier meat eaters. And that's where, even though it's a processed food, that's where the meat substitutes can come in really handy with men. And if they're struggling, I say, I'd much rather you have a fake meat burger than a real burger. So we have to have that balance.
Giving the information in a gentle and kind way is super important, but also not holding it back, as we have been doing so because of culturally we are trying to be respectful, we are trying to be very, gentle in a way, because I think some people do miss out on the information when we don't give it to them on a full plate. Ambiguity here.
And you're very right, Lisa, that we can't promise them they get pregnant. It's of course very important. And please don't get me wrong, I didn't want to say that. But for example, if you talk about period cramps, if you talk about low abdominal pain, if you talk about fibroids, if we talk about endometriosis, for those we can say that they definitely will improve if they go the full approach. Obviously, with fertility, we can't improve because there's loads of other, particularly psychological factors, which may block them in the end of the day. And that's why I was showing that slide as a reversal early on. We know that 50% of pregnancies are actually unplanned, and in many European countries they end up in termination, and in the UK would have a very high rate as well. But obviously there's the other side as well. There's probably as much of a figure there where there's infertile couples who won't get pregnant because of other psychological blocking factors, which may be very difficult to find out, and that's where the ACEs may come in to find some of these out, but you may not always find them either. But what you can say is that you at least will improve their adult mental health by sort of giving them a good gut microbiome. And yes, you will at least improve all their other factors which may be contributing to the disease, such as endometriosis, fibroids, high prostacyclins, PCOS, and so on and so on.
Do you both have a success story or an inspiring story to share with our audience, just to end on a more positive note?
Well, I can tell you my own success story, if that's
great.
So, as I said, I suffered with infertility. Well, I had very, very irregular periods for 10 years. And when I was younger, I didn't really think it was going to affect my fertility at all. It didn't cross my mind. I just thought I wasn't having periods. And some years could pass without anything at all. And somehow I managed to conceive my eldest son. I'm not sure how. He's 12 now. And when my husband and I were trying to conceive, we thought it was just happen and it wouldn't be a problem, and then it didn't. So we had IVF. I stumbled across plant-based nutrition during the treatment. Initially, I was skeptical because I'm a dietitian, and I was taught that dairy is the best form of calcium and that meat is the best form of protein. And I was concerned I was going to give my baby, if it was successful, nutritional deficiencies. So, I mean, cutting out meat wasn't a problem for me, but I carried on eating fish and dairy. And it wasn't until my son was 6 weeks old and got diagnosed with cow's milk protein allergy, and he was really poorly with it, that I just gave up dairy overnight because I was feeding him. And from that moment on, I was whole food, plant-based, haven't looked back. And within 2 months, my cycle had returned to normal, 28 days. And for the last 2 years, it's been 28 days, and there's not been an interruption. And that's an anecdotal story. It's not it's N equals 1, but still, for me, that was all the evidence that I needed to continue.
So incredible story. Ulrich, I know you have quite a few stories with your patient. Can you tell us?
Yeah. We find that polycystic ovaries is quite a prominent sort of cause for infertility. And we would have quite a few patients with that. And they may be both. They may be having a raised BMI, and there may be actually normal BMI. And the truth is the normal BMI sufferers often worse off. They're much more difficult to treat. So when they come to us, obviously we've done the assessment and all that. And I remember particularly one moment, so who was a BMI which the British public would now consider as normal, of 31. Most British people would consider as a normal BMI now in their own eyes. So she was coming to me trying to conceive, and her periods were quite long cycles, so 35 to 40 days. And we were measuring her day 21 progesterone. Her lipid profile was obviously all up, and her day 21 progesterone was very low. So she obviously didn't ovulate really. And then so she actually went for the changes. which was amazing because she was very reluctant and from a west of Ireland background and didn't really sort of feel that it was the right thing to do. But nevertheless, in fairness to her, she went for it. And every single month we checked her day 21 progesterone and it was going up and up and up over 4 months. And then bang, she was pregnant. And it was all beautiful and it was all lovely. And then, of course, there was a discussion then, what about the pregnancy and what would she do in that? And unfortunately, then her, like you said as well, Lisa, the concern from the general public, sort of, oh, you know, the baby is nutrient deficient, blah, 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 and all this. So she relapsed. And unfortunately, then her weight shot up during pregnancy and she got gestational diabetes and all that. And she just couldn't be reined back in, which was a bit sad story because she had seen it on her own body that it actually did her the world of good, that her periods did return to normal, that her ovulation did happen and it did get her pregnant. But still, it wasn't enough against the cultural background of a farming sort of community, you know, where beef and dairy is just sort of the thing you do, you know.
That's again just a perfect example of it's not the miracle, it's just that we have really culturally deviated from what our human body needs.
That's
a lot
right.
of fiber, exercise, and not working our lives away into stress for economical growth only, but we need to look at our whole life and the choices that we make every day with what we eat. And I often have this answer from patients that I don't have time to cook, I don't have time to shop. But unfortunately, if we don't have time to cook for ourselves and take the time for ourselves as an absolute necessity, fortunately, we'll need to have time reserved for illness in the future.
That's it.
Amy was asking about endometriosis, as Erica answered to that, but I want to repeat it. Everything that we do affects all of the diseases. It's not just endometriosis, it's not just PCOS, infertility. Everything is interlinked. So infertility just becomes a symptom because you're looking for a solution for that problem. But if you have infertility, you will have other problems in the future if lifestyle is not looked at and if the doctors are not starting to look at that as a whole. And that's why your approach is so great with the multidisciplinary approach. Is the best way to do it. So salute you on both. Incredible job. So check us out on YouTube, Instagram, and on our website. Become a member and let's continue this conversation there. We're here just to get you healthier, bring you the evidence that you require to live a long and fulfilling life without chronic diseases.